So excuse me that I have to talk again, but of course I'm very happy about that. And I think it's a very important topic, pain. It's a multifactorial problem, and we will go through some of them, not all of them, of course. And pain is so important, I think, because most of the patients have pain, most patients with chronic pancreatitis, and it's a real big clinical challenge, or to say it's many patients, it's really difficult for us to treat those patients, to help those patients. The typical pain, type of pain is constant, severe, dull, and epigastric pain radiating to the back, worsening after food intake. And the natural cause of pain, there was some hope, and the group from Zurich, from Switzerland, they said there is a burnout hypothesis. So they could tell the patient, you have to wait 20, 30 years and then it will be better. Because with the progressive fibrosis, the patient will have less pain. Unfortunately, recent studies, for example, NAPS2, the studies from the States, large number of patients shown, this might not be true. So there might not be the burnout hypothesis. Patients will unfortunately continue to have pain. So what is the reason for the pain, the mechanisms? So one of the first models was the pancreatic duct hypertension model of pain. And it was published in 1970. And it was a case report, actually. It was a patient with chronic pancreatitis who had a fistula between the skin and the pancreatic duct. And this doctor, he introduced a catheter through the skin into the pancreatic duct. And always when he injected fluid into the pancreatic duct, and especially with a higher pressure, more than 25 millimeter Hg, then the patient developed pain. So he said, wow, this is the reason why the patients have pain. The high intraductal pressure. And there were also subsequent studies intraoperatively that were measuring the pressure in the pancreatic duct before and after operation, and there was some data that seemed to confirm this. Yeah, but then further on we had also other methods to measure the pressure, endoscopic manometry methods to determine which is the pressure. And those studies could not confirm those observations from the 70s. So there was only one study, and they compared the intraductal pressure in chronic pancreatitis patients with pain and without pain, and there was no change in pressure. So the link between ductal hypertension and pain is still ill-defined. Yeah? But currently, there are still many colleagues, pancreatologists, who are following this notion: if there's a stone, there must be a high pressure in the ductal system, so I have to remove the stone. Yeah? But the evidence is quite low, I have to say. Then there's another model, parenchymal hypertension induces pain. And there was a Danish researcher, and he introduced a needle into the pancreas, either percutaneously or intraoperatively, and then he measured the pressure in the pancreas. And he measured really enhanced, elevated pressures in patients with chronic pancreatitis and pain. He did the same intraoperatively, and when he operated those patients, afterwards the patient had less pain and a lower pressure. After 1 year, the patients with pain had still high levels of intrapancreatic pain, patients without pain, lower levels. So this is an interesting model why patients have pain. It was also explained by like a compartment-like syndrome induced by the fibrosis of the pancreas and the peripancreatic fist capsule. And there are also some animal models who said if you inject secretin, there's a stimulation of secretion, parenchymal hypertension, and this is leading to acidosis, ischemia in the pancreas, and ischemia is a well-known trigger of pain. It's an attractive model, but still there are not so many studies. What is the link pancreas morphology and pain? So here are two patients, both alcoholic chronic pancreatitis. The first one, a stone in the pancreatic duct which is dilated. Does the patient have pain? A lot of pain or no pain? Who said this patient must have pain? Dilatation of the pancreatic duct, big stone. Who says patient's in pain? Pain? No pain? Most of them pain, yeah? Okay. But the other one, this is also a patient, lot of calcifications in the pancreas, the white spots there. A lot of calcium, mildly dilated pancreatic duct. A drinker, 1 bottle of vodka. So he has a lot of pain or no pain or moderate pain. Can we say this? Who has made more pain? Moderate or no? Okay, let's have a look. First one, stone, pancreatic duct hypertension maybe. She says, yeah, usually pain-free, but some episodes with mild to moderate pain. Interesting, huh? Second one, so classic alcoholic chronic pancreatitis, calcifications in the whole pancreas, pancreatic duct, no abdominal pain and no episodes of pain, pain-free. Interesting, huh? And this is an interesting study from Whitcomb and the whole team there, the whole group, North American Pancreatitis Study Group. More than 500 patients were interviewed, and they had to note which type of pain do they have. Yeah, 45% constant mild pain with episodes of severe pain. We know all those patients. Yeah, 20% usually free of pain, but then there are episodes of severe pain. Yeah, we know also those patients. 16% never pain, no pain at all. And then very few patients, 5%, constant severe pain. Those are our most challenging patients. And they were also looking for the morphology, and they said the pain was largely independent of structural variants observed by abdominal imaging techniques. There is no good correlation. And there are also other studies I could also show you that the correlation is quite bad. Yeah? So now I want to talk about the neural basis of pain, which is very important. And a little introduction. Nociceptors are sensory nerves. They sit in the pancreas and they transduce the stimuli into pain signals. So nerves in the pancreas, and the nociceptors in the pancreas, they are afferent nerves, and the cell bodies of those nerves are not sitting in the pancreas. They are in the dorsal root ganglia, which is shown here on the left side. Yeah? And there they are releasing neurotransmitters, activating the secondary neurons, transmitting the pain signal to the brain. Yeah? And in patients with chronic pancreatitis, they have pro-inflammatory cytokines in the pancreas and in the whole blood system. And pro-inflammatory cytokines and neurogrowth factors were shown to sensitize those nociceptors in the pancreas. They're sensitized, so low stimuli can induce pain, and specifically the growth factors, they induce a hypertrophy of the interpancreatic nerves. And the Munich group, they did terrific research showing this in many different publications. Yeah? So, and these changes, hypertrophy, neurogrowth, are strongly associated with pain in chronic pancreatitis. Yeah? And here one paper seeing here the hypertrophy, so large diameter of the interpancreatic nerves induced by growth factors and cytokines, and this is associated also with pain. But there are also central mechanisms of pain, or central, not only sensitization in the pancreas, low threshold, but also in the brain, low threshold. So the idea is long-standing intense peripheral stimuli in the pancreas result in an increased responsiveness of central pain. So it's become very sensitive in the brain for pain signals. And at the end is the patient feels pain, and this pain, kind of pain emotion, is no longer coupled to the presence, intensity of pain stimuli. So this sounds strange, but this is very important for us. So there is no afferent information or signal of pain, but the patient have pain, the brain. So, yeah? And this is one argument that the pancreatologists say we have to be careful not to do an operation when if the time point is too late, because then there is a sense of the pain in the patient, which is not longer coupled to the sickness from the pancreas. So the patient should have an early operation. Yeah. So in CP patients, they show a reorganization of the brain areas. So there are actually really changes in some areas which are very important for pain, insular, cingulate cortex. So, and those changes are similar to changes which are found in patients with phantom pain. So they don't have they have an amputation of the leg, for example, but there's still pain in the leg, which does not exist. So this is also interesting. After total pancreatectomy, not all the patients are pain-free. There are still patients who have pain. It's like a phantom type of pain. So we have a reorganization, and Aspian Dreves, a Danish group, this was really their focus of research, and this is a very interesting aspect, a neuropathic type of pain in patients with long-standing chronic pancreatitis. Yeah? So we have a wiring problem in the brain, on the pancreas level, lower thresholds. We have cytokines in the pancreas, but we have also other aspects which are contributing to pain. And this is what I shall show later. What is this? The type of pain. To compare chronic pancreatitis patients with intermittent pain versus constant pain. And this was also an interesting study. So the constant pain is more difficult for the patients. Patients with constant pain have higher rates of disability, hospitalization, higher pain medication, lower quality of life, and are more likely to have alcohol as an etiology of their chronic pancreatitis. So we have to be careful and take care, especially those patients with constant pain. They have a big problem. This is shown here. Number of hospitalizations on the left side. So the patient with the mild and constant pain, they have a higher number of hospitalizations. Quality of life is better with the intermittent type of pain, worse in the patients with the constant pain. So how can we treat the pain in chronic pancreatitis? It's difficult. If there are extra pancreatic causes, it's sometimes easier. If it's pseudocyst, we can do endoscopic EUS-guided drainage. If the patient has maybe an ulcer, taking a lot of NSAID substances, you can have a gastric ulcer, duodenal ulcer. Of course, we can treat it very easily, less pain. The patient should stop drinking alcohol, should stop smoking, because both factors are contributing to pain. And then analgesics. So we use the pain relief ladder, the stepwise increase with non-opioids. We don't start usually directly with opioids. Only in patients with severe pain, we have to use a top-down approach. So with this severe pain, they need opioids. We cannot wait. We can start with paracetamol, but most patients will continue to have abdominal pain when we use paracetamol only. But of course, combinations of paracetamol and opioids is a good idea. So what kind of other medications do we have? Codeine, weak opioids, have all other side effects of opioids. Tramadol appears to be maybe more efficacious than morphine in some patients, fewer gastrointestinal side effects. Many patients have strong opioids, morphine, which act on receptors, and this is a big problem. Those patients were standing on opioids, and usually they take tablets. Some few patients, they can also use patch formulations, but higher cost we have to take into account. It's more expensive, so very few are taking those patches. In general, opiates are not very effective in treating established central sensitization. Yes, even those strong opiates are quite bad to treat those neuropathic type of pain. And the opioids, they have also a side effect, the narcotic bowel syndrome. And we have this problem with our IBS patients, there are also many patients who are on opioids. So those patients have strong abdominal pain because of high doses of opioids. And if we reduce the opioids, the abdominal pain will be better. So the Danish group, they published a study based on the concept of the neuropathic pain. Why not try to use pregabalin in those patients? And they found an effect in 64 patients with chronic pancreatitis, and the change in pain score was more significantly compared to placebo when treating patients with chronic pancreatitis. And more patients said, yes, my pain improved in the group taking pregabalin. So pregabalin caused more effective pain relief after 3 weeks of treatment. And you know the Cochrane analysis, and I think it was interesting. I was a little bit laughing when I say this. It's a Cochrane analysis we all know for meta-analysis, and this Cochrane analysis says we only found one study which met the inclusion criteria for this review. And this was the study from Denmark. Yeah? They were quite strict, and they said only the short-term outcome was available, and this is one reason that they said the overall quality of evidence is low to moderate, and they said we need further studies. Pancreatic enzyme supplementation, there are still colleagues who treat patients with enzymes in the hope that this will have an effect. But there is a meta-analysis, 1997, an old one, which shows that enzymes have no significant benefit when treating pain in patients with chronic pancreatitis. Antioxidants, which were also already mentioned, there's one larger study published Gastroenterology 2012, and they found no effect on pain and quality of life. They evaluated 70 patients. Then, of course, there are other studies, and this is also a meta-analysis, 12 randomized control studies, all using antioxidants, and 6 were even double-blinded, placebo-controlled. They used this antioxidants, vitamin C, A, vitamin E, glutathione, yeah. And the idea, why are you using antioxidants? They say the patients with chronic pancreatitis, they have lower levels of antioxidants, and they have increased level of free radicals. So they need antioxidants. Yeah. But The study showed 16% have side effects, like headache, GI symptoms, and there was a significant reduction, but this was on the VAS scale, very small difference, 0.34. 1 to 10, 0.34 reduction. Very small effect. So they were wondering, is this really of clinical relevance? And the routine use cannot be recommended, especially when we have to take into account 16% had side effects. So I'm not really convinced. Maybe subgroups will have a benefit, but the evidence is not so strong. What about thoracoscopic splanchnicectomy? Yeah, so it's a thoracoscopic intervention, and it's also a meta-analysis here published 2008, which shows the morbidity, complication risk is quite high, 17%, like hypertension, for example, hypotension. And what about the success rate? Success rate, reducing pain, less than 6 months. 90% of the patients said, yeah, I have less pain. And after 1 year or 15 months, half of them said, yeah, they had a bad benefit. But it's not a widespread method to treat patients with chronic pancreatitis. Reduces pain and improves quality of life for patients with chronic pancreatitis. What about plexus neurolysis, plexus blockade? We use predominantly for the patient with pancreatic cancer. This is also meta-analysis, 8 studies versus 9 studies, and pain relief in pancreatic cancer, 80%. So those patients with really palliative situation, strong pain levels, they have a benefit when we are using the plexus blockade, which we can do quite easily by endoscopic ultrasound. In chronic pancreatitis, pain relief, 60%, a little bit lower. But the thing is, the big difference is the median survival of patients with chronic pancreatic cancer is quite low. But the young patient, 45 years old patient with alcoholic chronic pancreatitis, he will live decades. And the effect of plexus blockade is 3 months maybe. 3, 4, 5 months. So this is the big disadvantage when we are using this method. So we already heard, and I have to confess, I'm not a surgeon, I'm a gastroenterologist, endoscopist. Surgery appears to be better than endoscopy when treating painful obstructive chronic pancreatitis, and it was already mentioned 2 main studies, 2003 and 2007. Surgery, more patients had pain relief, more patients had improved quality of life, improved preservation of exocrine pancreatic function, but I could say, yes, but surgery has a higher complication risk compared to endoscopy. No, the surgeons are really good nowadays. There was no different complication risk. Conclusion, surgical intervention resulted in a higher percentage of participants with pain relief. So don't wait too long to operate those patients. Then there are some new fancy methods, spinal cord stimulation. We've seen 7% of our patients have constant severe pain. And this is a big problem. So what about spinal cord stimulation? Maybe we should try this. 30 patients were treated here. So so a catheter is placed on the spinal cord and they get a stimulation for 1 or 2 weeks. And what are the results? 80% reported at least 50% pain relief at the completion, at the end of the study. The VAS pain score decreased from 8 to 3.7, which is quite good, I think. the opioid use decreased from 165 to 105, which is also not bad. Yeah. So I think we need more data, but maybe it's also an option we could go for it. And this is also an interesting chapter. I can only mention it very briefly. Why not do a total pancreatectomy? Those patients, terrible pain, opioids, they see the doctor every week, emergency unit, and so on, and so on, and so on. Why not do a total pancreatectomy? And this is a study from the States, 46 patients, highly selected patients, and they did an analysis, and the monthly narcotic use decreased from 138 to 37 morphine equivalents, and also very interested, it was associated with a significant decrease of the costs and increase of the quality-adjusted survival. Yeah, if you see this here, patients medically treated, medical treatment, they come all the time to the hospital, new treatments. The patients after the total pancreatectomy, hospital days went down. Admissions went up. After total pancreatectomy, admissions went down. Yeah. Imaging went up in the medical treatment group. After total pancreatectomy, went down. So they concluded providers and insurers should more enthusiastically embrace total pancreatectomy with islet cell autotransplantation as a more effective cost-saving strategy. I think it's an interesting way to go, and sometimes when I have those patients with terrible pain and they are 40 years old, they cannot work, they have a terrible life quality, I think maybe there are candidates where we should go for a total pancreatectomy. Thank you very much.